Happy Friday, everybody.
It's been a long week, man. It's great to be here, though.
Robert Kerstein, welcome.
Thank you for having me.
Oh man, it's our pleasure. We were just talking ahead. We're a little slow tonight. We had a movie premiere last night, which was a lot of fun, but like Tom said, it was an atypically late evening for us. So. So here we are. Cool. Well, welcome. Where are you at, Robert?
I'm in Boston. Still Boston.
Wow. Okay. So one of the executive producers. I think there was 3 or 4 people from Boston up there.
Yeah.
Todd Otten was up there. Yeah.
We had a lot of Boston contingent last night.
Well, I hope it went over well. The movie being well received.
Yeah. No, it definitely did.
It was definitely an important message. So I think. Patients are fed up, doctors are fed up, and what can we do about it is the next step of that equation.
Yeah, you guys enjoying a second winter up there like we are down here in Baltimore? It was like 80.
I really like the winter. So
got it.
A good storm is without too much human toll, is a fun experience in the winter ever since I was a little kid. So
nice.
I'm a big skier.
It was amazing.
I wish the skiing season could last all year. That's my winter addiction. So for sure. So Robert, tell us a little bit about yourself. How'd you come to do what you're doing?
Well, I was very fortunate when I was a dental student to graduate and go on to do prosthodontics, which is a specialty in crowns and bridges, and these days it also involves implants. But I was exposed to the first T-scan system, which was built in 1984. My teacher actually built it, a professor of mine at Tufts Dental School, with some engineers from MIT and collaborative funding from Tufts Dental, Boston University Dental faculty, and Harvard, a small amount of Harvard faculty. And the school allowed me to research with it, and I began to discover a lot of things with it. It was the first computer technology in dentistry, actually, and it preceded all the technologies that are being used routinely today by many years. And it was amazing advance over using articulating paper and ink to try to determine bite pressure and forces. And so I discovered a lot of things in those years by researching on dental students about the bite and the bite mechanics, and that just grew as we discovered more and more things like how to stop TMJ problems without you needing night guards or Botox or medications, or things like how to improve chewing mechanics using bite adjusting, computer guided bite adjusting, how to stop cold sensitive teeth without needing to bond over the teeth or try to use medications to deal with cold sensitive teeth. So through the years, we've discovered many, many, many solutions to common bite maladies that stemmed out of my research at Tufts from 1984 to 1998 or so. Those were the foundation years.
That's quite a foundation. That's not.
God, I want to ask about the teeth sensitivity. How does that show on imaging?
Well, it's more of a response to what you can do to the teeth. So cold sensitivity is a function of any microtrauma in the body. It's not just on teeth. Creates a vascular shutdown. So an example would be if I keep tapping on my skin, it's going to turn white. Yeah. And that's microtrauma. So what's happening is the skin is losing, you can see it a little bit right there. It's losing vascularity. So when teeth are struck too often, too frequently, not necessarily too forcefully, but it's more frequently, the blood supply shrinks away from the nerve that's in the teeth, and that exposes the nerve to thermal insult that's outside the tooth. So the blood supply keeps the nerve warm, essentially. Yeah. We discovered years ago that we could actually reverse that process very quickly with computer-guided bite adjusting, micro-adjusting of specific tooth contacts and timing, all related to the T-scan data. And cold sensitivity goes away very quickly, actually. We often do live demonstrations, where we give the patient ice water. They cringe from the ice water, and they try to swallow it, and we make them swish it around their mouth for like 5 seconds. Then we treat their bite with the computer-guided metrics of T-scan, micro, high precision adjusting, and then we give them new ice water. 45 minutes later, essentially the process might take 45 minutes to adjust their bite with these key metrics that the T-scan measures. And then they drink the ice water, and it's fascinating. They can do it. And you see a drastic difference in them. As soon as the microtrauma is removed from the teeth, the blood vessels re-emerge, just like my skin. As soon as I stop, right, the skin color comes back, the white goes away, the blood vessels reappear. And the person can then eat ice cream, and they don't have to leave food out on the counter to get warm from the refrigerator, and they don't need to wear anything or do anything or take anything. And this is because of the intense neural connection that the teeth have with the brain and with the blood supply. It's a really amazing. The T-scan allows us to control the neurophysiology of the bite mechanics to very high tolerances that can't be done without it. And so there's many reaching solutions for common maladies. Just to tell you that process, the ice swish, we did a study on like 150 people, and the statistical changes in their cold sensitivity is amazing. You know, there's just drastic reductions in how cold the people feel the teeth right away. And
interesting.
You know, yes, so it's again high precision micro adjusting, computer guided, allows us to control the neural response of teeth back into the brain and then out from the brain. And this is what T-scan research has borne out now for the past 42 years. And
it's funny because I never would have thought that neural activity in the teeth would be that influential, I guess, in outcome. I never put those two together, actually.
Well, dentistry is with you on that. Dentistry doesn't understand this intense neural input to the brain. The dental students are always taught things like, well, there's all this sensitivity, neural, the teeth and the trigeminal nerve are the biggest nerve in the human body, other than maybe the 10th, the vagus nerve. They're talking about sensitive response, touch and tactile sensitivity, not motor activity. It's actually the neural control from the teeth is designed to tell your brain, and you actually know this, but you don't know it in consciously, how to chew food, eat the food, swallow the food, push it down into your stomach rather than into your lungs, where you would asphyxiate and die. All of that is controlled by the teeth, and it goes on unconsciously. In other words, you're chewing and eating, and suddenly you decide to swallow, and the food just happens to go down into your stomach, and you don't really think about it, and you're able to breathe during all of that and not choke. And if that neural control wasn't there, food often goes down into the lungs. And this happens to elderly people who lose teeth. They actually have to have sometimes a feeding tube put in because they lose their swallow mechanism. So the swallow mechanism is a huge survival skill that the teeth modulate into the brain and out of the brain. And T-scan guided micro high precision adjusting, as I said, can control that neural relationship in an incredible way. And it actually promotes healing from within the person's central nervous system.
Wow. That's pretty cool. So is that the glossopharyngeal nerve then? Does the teeth have some control or dominance over that?
It's a great question. So yes, indirectly. And the reason it's indirect is because the trigeminal nerve, which is the main nerve that the teeth operate on and talk directly to the brain with, also the trigeminal nerve is used by the glossopharyngeal nerve and two other cranial nerves, the facial nerve and the oculomotor nerve, which is your eye muscle nerve, to get to their end structures. So in other words, the teeth are talking to these other nerves by those nerves jumping onto the trigeminal nerve to get to where they have to go. And the glossopharyngeal nerve, which controls the tongue, the base of the tongue, and the pharynx, nasopharynx, oropharynx, is involved in tightening up the sleep musculature. And a lot of people have compressed airways because the teeth tighten up the muscles associated with the glossopharyngeal nerve the same way they tighten up TMJ muscles, which would be facial nerve and masticatory muscle nerve innervation. And we've actually found, it's a great question you asked, Tom, because we've actually been, in the last several years, discovered that we can open the airway by doing T-scan guided micro adjusting.
So this would be like in lieu of a CPAP or sleep apnea, these kind of things. So it's fascinating because when we learn the cranial nerves, right, we get that slightly dirty acronym, and you don't think that there's an intertwining of those nerves, right? This one does this one does this one does this. I said it a couple of times last night. I'm just a lowly acupuncturist, so my depth in neurology kind of stopped after memorizing, all 12 of them. And it's kind of crazy to see. So can you talk us through some of what do these micro adjustments look like? Because,
same thing.
Clearly, we're headed towards TMJ disorder and those kind of things that we're talking about here. How does it work? I understand needing the precision imagery because we want to know how the teeth are making contact with each other. But what is the intervention of that?
So the main problem with teeth that is not, again, well understood by dentistry is not how they land or what they look like alignment wise or how pretty the smile is. It's actually friction on the back teeth that promotes high muscle output, electrical output, and makes the muscles of the head and neck through the brain connections work overtime. And this is where many symptoms come from. So what we're treating with the micro adjusting is duration of friction, and it's fractions of seconds that you can measure with the T-scan technology. The T-scan person bites on this electronic wafer. It has 2,000 pressure measures that are charged electronically and measured over 3,000ths of a second at a time. So you can separate out the pressure mapping and the duration of contact into fractions of seconds, dramatically, actually, 3,000ths of a second. We can't see any of that with our eye. And so these teeth rubbing together frictionally for time and distance causes excess electrical output to leave the teeth and travel directly into the brain, where there it talks to posture centers and swallowing centers, breathing centers, and then it comes out on those nerve endings in those centers and creates these kinds of problems. So to answer your question, the micro adjusting is to remove the friction down to very small durations. And it's done on the surface of the teeth. There's no damage to the teeth if the bite is reasonably healthy. There's no damage to the teeth if the teeth themselves are reasonably healthy. If someone has very worn teeth because the friction has destroyed their teeth through years of it sort of sanding away their teeth, maybe they can't go through the micro adjusting, but the friction can be treated by building back better tooth shapes or by improving the dental function by maybe looking at how the front teeth have been sanded away and rebuilding them. So there's a lot of ways to deal with the friction, but the main treatment, to answer your question, is to use the dental drill and the T-scan data, and you correlate the locations of excessive friction with the articulating paper, which is how we mark teeth. But the real important difference for the listeners to understand is the articulating paper measures nothing about the bite, and the dentists don't want to face that. It just puts ink on the teeth, and it can't measure friction durations, for example, in 3,000ths of a second.
Sure.
It's kind of like a smear across the tooth, looks like friction, right? And with the T-scan, we can determine the duration of the friction. We can determine the pressure mapping of the friction. So it could be light friction, it could be moderately forceful friction, it could be exaggerated friction, which repeatedly will crack a piece of the tooth off or will cause the root to crack maybe 3-4 years later than the friction's been there for a while, and all of a sudden the patient gets a toothache and their tooth cracks from the friction. So the friction is just like any friction, like tires on the road driving or rubbing our hands together, right? But the tooth friction makes for exaggerated muscle output from the back teeth especially. The back teeth are designed to promote chewing, eating, and swallowing, and their output to control the process we just talked about, chewing food, swallowing it down your throat rather than going into your lungs, that whole process is what causes damage to the system if it operates with too much muscle activity. So the damage can be dental damage, for example, sanding away the teeth mechanically because too much muscle force is applied to the teeth, and then the teeth get worn away by rubbing together frictionally. Or the teeth can be preserved, and the extra output then tires out the muscles of the jaw, which is where TMJ comes from. The friction causes TMJ, and it also tightens the airway, which you were talking about. And the beauty of the microadjusting is it reverses this process of excess muscle activity leaving the teeth. And then, unlike using a CPAP, because you mentioned CPAP, the person's airway naturally opens. And the difference is not only do they not have to wear anything, but they sleep much deeper without having to wear anything. And whether you use a CPAP or use a snore guard or use a mouth guard to try to open the airway, in the morning when the person wakes up, the airway isn't bigger. It didn't get any bigger. It didn't expand. It didn't become much wider on its own, right? It's still compressed and tight because the swallow mechanism hasn't been addressed. The swallow mechanism is at the core of most of these chronic bite-related maladies that might be treated with repeated acupuncture, for example. That's a symptomatic approach, or appliances, or physical therapy, or Botox injections. But none of them can reverse the electrical output of the posterior teeth. And that is where the system really, it's why you have to keep doing acupuncture, for example, right? It's why you have to keep going back to get Botox, because nothing internal has been changed, only trying to relieve the pressure, the electrical pressure in an external way. So the beauty of the frictional microadjusting is it stops it from within the central nervous system. And we know this because we work with EMG simultaneously with the T-scan electromyography, and we can see the muscle activity goes way down in the visit. You can tell right away that there's been a massive change to the patient within the treatment session.
So it almost instantaneous, like the cold water and the sensitive teeth there.
Essentially, usually the patient has a when it's done properly. Before I just clarify what you asked me about, the important thing is to realize the T-scan doesn't work because someone owns one. A clinician has to be highly trained to get these results, and that's been an issue in dentistry. People will study the T-scan and say, "Oh, it doesn't work. The sensor's no good." They don't know how to use it. It took years to figure out how to use it to do these things, right? It's not something you buy and it just works. You stick this in somebody's mouth and have them bite on it. You have to know what to do with it, how to get that data that's quality, that's high quality, that they can read, that we can analyze correctly and make intelligent decisions about. So a dentist who has one isn't necessarily a highly trained expert. That's something else we can talk about.
Well, how many people have one of these? Let's start there.
Yeah, how common is this?
I would say in the U.S. it's probably 5% of the dentists have.
Holy shit, that's not a lot of people at all.
Yes, and that's because dentistry has kept it down, and that's been something that's been going on since the beginning, since the 1980s. Dentistry doesn't.
What's the motivation to keep it down, though?
Well, that's a very good question, Matt. I don't actually have the answer to that, because if I did, I would have solved it by now in 2 years. But the nature of it is the T-scan has disproved all the beliefs about the bite, and things like how the teeth should hit and what they should do and what they should act like. And these are all perceived non-neurologic understandings. They're biomechanical understandings that are taught to dentists. And a simple example is like the paper marks can tell you about the bite force and the bite timing. That's a belief system in dentistry. You can't do it at all. Ink and paper doesn't measure anything about the bite. It just smears ink on the teeth. And that can be useful, but not in terms of treating central nervous system neurologic issues like TMJ or sleep apnea, for example. And so dentistry doesn't seem to want to face that there's a need for higher level care for the patients in favor of academic resistance to a very superior technology to the method that's commonly used and taught. And so the T-scan has been kept down by the profession at the expense of the patients and at the expense of the dentists, for that matter. Dentists struggle with bite problems all the time in their practice. They don't get resolution. They have patients who come back from multiple bite adjustment visits after getting new teeth They have implant cases that break. The implant world has a huge problem in complications. And we published a study a couple of years ago that showed if you use the T-scan to install your implant cases, you'll have a 23% less chance of having complications. The complication rate for non-implant installed complications was 25%, 1 in 4. The complication rate for T-scan installed implant cases was 1.8%. Right? Think of that difference. 23%, right?
That's huge.
And that's because you're essentially, when you're implanting, you're correcting those instead of having to do the micro adjustments. You're building that into the tooth itself, correct?
No, it all has to be done through micro adjusting. That's why the T-scan is so important, because the normal insertion process is the dentist uses carbon paper and ink and guesses at the ink spots and tries to make them look a certain way and thinks that balances the bite. But we've proven that with the T-scan, you can't look at the ink marks and know what the forces are. Big marks can be low force, little marks can be very high force, medium-sized marks can be any force. So the ink marks don't predict anything about the bite that the dentist can use, and that's been proven, right? It's also been proven that dentists can't choose the marks very well. In other words, you have a filling done, and you bite down on the paper, and the dentist then decides by looking like which one he's going to adjust, and very often that leaves bad forces on the teeth. Very often that doesn't correct the problem, because the patient might say, yeah, that feels okay, that feels better. But then a few days later, they have to go back and they say, Dr. Smith, I got my new fillings and that side doesn't feel right. And the dentist doesn't really know what to fix. And using the principles that have been taught about how the paper marks measure force is not true. It's not scientific. And so, again, here's an example of what the T-scan has disproved. And so dentistry doesn't want to face not only the fact that the common method is really bad for patients because it's highly subjective and it is not precise at all, and dentistry doesn't want to face this incredible neurologic control the teeth have with the brain. Second to the heart electrical system and the brain, the teeth are the third most important neurologic system in your body. And dentistry doesn't think that. Dentistry doesn't think the bite has a role in TMJ. It doesn't think it has a role in periodontal disease. It doesn't, the bite.
How does it not think the bite has anything to do with TMJ? I would think that would be only related to the bite, no?
Well, it's a great question. It's been advocated repeatedly that it's a psychosocial problem, that's a stress-caused malady, and none of that is true. And actually, this is a great question you asked. We just published a paper that showed if you do these T-scan guided micro adjustments to the friction, you actually reduce salivary cortisol, which is the stress hormone, by 50%.
Wow.
And, right, and not 10%, not 3%, 50%. And there is a wellness effect that people have when they go through the T-scan guided micro adjusting that is they finish the visit and they're like, wow, that is so much better on my face, and there's so much less tension in my jaw, and it's instantaneous. So the brain receives this electrical input from the back teeth that's too much, and it sees it as a stressor, and it creates cortisol as a response to that stressor. It's an electrical stressor, and it's nothing you can see organically. Like, you can't take an MRI and see this electrical activity. You need EMG to see it externally. But the system is designed for the teeth to talk to the brain. And so the psychosocial aspect is untrue. If we were able to do the bite adjusting and the cortisol levels didn't change, that would mean that the bite had no influence on the brain chemistry, right? But the cortisol changed dramatically, right? 50% reduction. And
that's crazy.
It shows you the power of not only the neurologic tie-in between the teeth and the brain that can cause the brain to release cortisol because the teeth don't operate well. And that's not a function of how they look. It's a function of the friction that we were talking about. You can have a perfectly looking bite and have terrible friction in it. And this is something the orthodontists don't want to face. The orthodontic community creates a lot of friction when they do Invisalign and when they do tooth movement with braces. And yet, they don't feel they need to finish the cases with the T-scan technology. So there's this academic barrier to all the benefits that the T-scan offers dental patients and dentists themselves that has been researched and published. These are not, I'm not telling you things that one study was done. Yes, one cortisol study was done, but that same microadjusting process has been testing cold sensitive teeth. We talked about that, TMJ symptoms for years and years and years. Don't need night guards to treat people. People stop clenching and grinding. People stop waking up with headaches. People feel a lot less general weirdness, brain fog. And again, this is because we can alter the brain chemistry in a very positive way. So the answer to your question is not understood why dentistry doesn't want to adopt this technology.
Wow. It's so funny because you hit me with so much right there that I'm kind of like chewing on all of it. No pun intended, I guess. But in part of it is in my head, I have this kind of chicken and egg kind of scenario, right? Because you know that stress tight posture with the jaw being tight, the shoulders being up. Is that the stress and then that's the cortisol, or is it the teeth doing the driving there? And it seems like if you're correcting, through those micro adjustments, the teeth, and this goes away, it seems to drive at least the hypothesis that it's a functional thing, right? It's not necessarily an external stress. But I'm also interested because I think you weren't dancing around it, but you kind of, this would have implications on other areas of the body by correcting the teeth, correct? I mean, you're going to see that manifest in other, you mentioned posture in other areas too. I mean, is there, I guess I'm asking, what's your weirdest story here?
Yeah, like
when you've done this, like what if somebody came in and said, "Hey, my constipation went away, or I don't have hemorrhoids anymore," or something crazy like that?
Well, we've
hilarious.
done studies that show forward head posture can be reversed in a matter of an hour, and then improves dramatically over the next 4 to 6 months. Yeah, we have a 90 patient forward head posture study. We have Meniere's disease, hearing loss in one ear studies. We have clenching and grinding studies. Yes. So hearing loss in one ear is a function of usually too much bite pressure on one side that the T-scan can isolate, and exaggerated friction combined with too much bite pressure. And then because if you think about swallowing, you are on an airplane and you want to clear your ear, you swallow, right?
Sure.
Yeah.
So ear function is greatly impacted by swallowing, and the bite mechanics control that. When you want to swallow, you put your teeth together, and that is what opens your airway by contracting a muscle that covers the eardrum. So there's an incredible number of possible combinations. The brain receives the electrical input in a structure called the reticular formation, which the electrical input from the teeth. The reticular formation is a massive brain center. It controls circulation, respiration, sexual function, digestion, and posture. And so this extra electrical activity goes in there, right? And now all these other regions are being affected by this extra electrical activity that the teeth are just making just by being used. And so that creates changes in those regions. So you mentioned something. I'll tell you a very good story, but I wanted to address your question about stress.
Yeah.
You can have stress in your life, and that can make you clench your teeth or bite down and take that posture you so nicely showed us.
Yeah.
When you have the micro adjusting done, the teeth don't magnify it anymore. So the problem is when people have exaggerated friction in their bite, they are unaware of that. And when they have a stressful moment, their mother-in-law moves in, their child gets sick, something goes wrong in their life, their boss comes down heavily on them for making a mistake, they may clench and grind their teeth and stress out over it emotionally. But when the teeth have been corrected in this very high precision fashion, the add-on effect from the teeth is removed and they can't make it worse. Whereas when you have the normal friction in your bite, it just drives on the exaggeration of the stress being applied to your emotional system. It's not causative, it's additive. And so the beauty of the cortisol study shows that we can reduce the stressful response a person can have by eliminating the tooth input to the brain in a very marked way. 50% reduction is a tremendous
Huge.
Yeah,
reduction.
that's not
Yeah.
insignificant.
So, but the story, we don't have a come to Jesus moment, dental story, but there is a typical story that really typifies exactly why the T-scan is so important, and it's a dental problem. It's not a TMJ. It's a TMJ problem in a way. But I was in Brazil teaching a class, and every few hours, a new patient would be brought in to look at with the bite computer with the T-scan data. And later in the day, a woman came in and she's speaking in Portuguese, and she's crying in the chair, and she's talking about how she had her mouth rebuilt, and she had beautiful caps. She had these 28 gorgeous caps. The artistry and the tooth forms were amazing. Movie style like stuff, and really beautiful. But it didn't matter because she, for the past 3 years since they were installed, couldn't use them. Every time she bit down, she got facial pain.
Oh, wow.
She went back many, many times to the dentist who made the teeth, and she went to see other people and who didn't make the teeth. And somehow she found the dentist who was hosting this T-scan program. And so we put her on the T-scan. As her complaint was, all she had to do was bite her teeth together and pain would go up her face. And this was going on from the beginning, right? It didn't evolve. It was like she left the office and that day she had this problem. Now it's 3 years later. And she's crying. She's in agony. She can't use her teeth. She spent a fortune. No one's been able to help her. So we put her on the T-scan, and her problem was, she said, you just have to bite down. So you can record biting down, like tap, tap, tap. You can record chewing around, grinding your teeth. You can record all kinds of different things. Parametrically, you have to know what to look for. But the motion we needed to record with her was just biting down on her teeth. So we had her bite down 2 or 3 times. And all of a sudden in the data with these massive pressure peaks that showed up right away before all her other teeth were hitting, 2 of them on one tooth in the back. And this is the beauty of the timing aspect of the T-scan. Like I said, you can measure timing duration. So the timing showed that these massive forces in 2 places were on one tooth way before the rest of her teeth hit. Even though if you looked in her mouth, it would look like all her teeth were hitting. So essentially the pressure was rising dramatically in these 2 places. We went in with the carbon paper because essentially what you do with the T-scan is you record it, then you figure out what's wrong, and then you take the carbon paper and mark only those specific places where there are problems. You don't look at the marks and say, I think that one's a problem, and maybe that one's okay, and that's completely eliminated, which is very important for the public to understand. The dentists are just looking at the ink and guessing, and we've actually studied that. We talk about that separately if you want to. So we put the paper in. Up on these two places which mapped out to where the high pressure was, so these 2 very small paper marks that every dentist who saw her up until this moment discounted and said, well, those are little paper marks. They don't mean anything. And yet pressure is inverse to surface area. So very often small marks can be huge pressure gradients. So I had the dentist hosting the course adjust these 2 places only. And this is one recording, one adjustment, right? 3 years now, the patient's been in agony. She starts biting down and she starts crying again, but she's crying in happiness. She's hugging the dentist. She can bite down for the first time. The dentists attending the course were stunned because this woman was living the dental bite nightmare. She got all this fancy dentistry done, and it caused her all these problems, and no one could figure out what was wrong. And if those people 3 years ago had the T-scan, they would have seen the same thing, and they would have taken care of it with the micro-adjusting, computer-guided micro-adjusting, and then the case wouldn't have created this problem for this patient for 3 years that totally ruined her life. And she was amazed. And of course, the dentists in the room were amazed. And that problem, patients going home with bad forces on their teeth or bad timing, is so common. My practice was filled with people coming in to see me who would tell me the same kind of story. I had 3 crowns made 3 years ago. They kept grinding on my teeth. My right side doesn't work, and now I have TMJ. Or I had some implants installed. I got my fancy new teeth, but I can't chew with them. It hurts to bite down. The same problem, and it's all tied to the paper marks. It's dentists using paper and ink to adjust the bite rather than using computer technology, right? Which what people don't understand, the last thing I'll say about this is these sensors this is the dental one. TEC scan sensors are used all over the world in aerospace, robotics, machining. The military uses them. They're used in podiatry. They're used in tire tread manufacturing. They're highly sophisticated devices, and the dental patient would benefit dramatically if they were used routinely because of what they measure. You know, your brake pads, your car, when you leave and go home after your podcast, you're going to drive in a car the brake pads were machined by TEC scan sensors, so they operate correctly and they last longer and they don't wear as badly. And so dentistry just doesn't understand the value that these sensors bring to the dental public and to the dental practice.
So, I want to ask about a weird one. You mentioned some ear issues. Could this help with tinnitus?
Yes.
Do you see that as another pressure type situation?
Yes. The ear studies we've done have been more about hearing and dizziness, vertigo. Yeah. The T-scan greatly helps with. But in treating people, I saw very sizable improvements in tinnitus. I would say reductions in tinnitus are common with T-scan guided microadjusting. I would say curing tinnitus is probably less common. So
yeah, it seems to be infuriating. Everything I've looked at from traditional Western medicine to Chinese medicine, there doesn't seem to be a switch to flip, if you will. But I can see, especially with what you kind of told us here about, how involved, and it makes sense from that homunculus model we learned, right? How much of the the brain is donated to head and face, that chewing in your teeth would have a significant amount of mapping there. I don't know if that model still holds up, but it definitely does seem to be the case there. I'm intrigued. You said so 5% of dentists in this country or in the world?
There are some countries where there's a prolific T-scan use, but the population is so massive. For example, in India, there's a tremendous interest, and many dentists have the T-scan in India and have learned the microadjusting. But I would say 2 to 5% is probably the ongoing rate. And it's because of active education, academic, political resistance. It's not in the best interest of the patients for dentists to guess at paper marks and ink. And yet that doesn't want to surface. Even though it's been published, there are 4 studies that show the dentists choose the wrong marks 90 to 95% of the time.
Wow.
Yes. And these studies give the dentist a paper mark picture to look at, 4 or 5 teeth, ask them what's the most forceful contact in the picture. They report a number. Let's say there are 6 paper marks to pick from or 8 paper marks to pick from. And when we do that, most people get it wrong. And that's why it's 90 to 95% wrong. And it actually is a very common thing. I don't know if you've ever experienced it, but if you have any dental work done and it seems off in your mouth, and then you say to the dentist, well, Dr. Smith, it doesn't feel right. And they go in and mark it again, and then they grind somewhere else that they think it should be ground. Very often the patients will say, no, it's not the right place. It's still the same, still high. And so the dentist doesn't even register that it's wrong, right? They're not thinking, oh my God, like I just ground the wrong place. And, it's so common to the mechanics of how bite adjusting is done that no one questions it. And the schools don't want to face that it's a terrible method. They still teach the outdated method rather than measuring and using computer guidance, despite using computer guidance in many other disciplines. It's a very strange resistance. And the sad part is, when I lecture about it and show dentists, I'll do a test. Many times in my lectures, I'll do a 45-minute, let's pick the highest force contact in the picture test. And again, the group of 20 or 30 or 40 only gets 11%, 8%, 9%. And what this means to the public is terrible. It means that, not only does the dentist not know where to adjust, but depending on which office they go to, they may get a better outcome, they may get a worse outcome. And dentistry doesn't think this is a problem. And when I lecture, I say things, so, okay, you don't seem to mind when you got it wrong, and nobody says anything. I said, how would you feel if it was an eye surgeon was guessing in your eye, or a knee surgeon was guessing in your knee? Why is it okay to guess in the mouth when teeth are so critical? Teeth are critical to chewing survival and breathing correctly and sleeping correctly. And all of this is just lost on the profession. And there's no answer to why there is resistance to this amazing technology, which has so many proven benefits.
I just want to go get it done just to do it. Be like, hey, you know what? Grind me down, get me all straight. And
I'm worried about my my orthodontics from years ago.
Yeah, I just want to get ahead of it.
Well, that's a very interesting point, to do it prophylactically. I don't think we are at the point where I would recommend that to you, unless I could see either in your mouth that you had wear and tear on your teeth from, let's say, the friction, or you had gum recession from the friction, or you had TMJ symptoms from the friction. So someone who's very healthy, their teeth are perfect, they don't complain about having tight throat and soreness and headaches, even though they might have friction in their bite, it's not warranted to treat them because it's not superseding their tolerance to their own well-being. So there has to be a evidence of some either dental destruction,
right?
Like I said, gum recession, wear, cracked teeth, root defects forming around the gum line where the dentist says you're brushing your teeth too hard. That no one brushes those 3 teeth away specifically at night. The 3 with the gum recession. No one, tonight I'm going to work on those 3 roots.
Yeah.
That's where I'm going to brush. The bite being unbalanced and being excessively friction-based will cause a lot of damage to the teeth in susceptible people. In other people, it'll cause damage to their muscle comfort, their headaches and stress level, their facial pain, their chewing capability. Essentially, the teeth work the swallow mechanism into an ischemic state, which is the same as if I was to weight train and do this with my arm, right? I'm going to get an ischemia in my bicep.
Yeah.
The teeth are doing that to the swallow mechanism all through the life of the patient. And so the people that are susceptible develop symptoms where they may have headaches and facial pain, or get a tight throat, or their airway might get constricted from the same tightening up of all these swallow mechanism muscles. So the teeth are sort of doing it insidiously just by being used. And so if you had some of those things, Matt, tooth-related damage, gum disease developing where you actually floss and brush fairly predictably, where you had wear or you just had symptoms, then it would warrant stepping in.
I mean, I'm just thinking, if you get a crown, I've got a couple crowns, when you get a crown, they got it, they do the 3D imaging, and then they do some, bite, tap, with the paper and stuff. And I'm like, all right, well, if we're already tapping, let's kind of
step it up a little.
Let's step it up. I mean, why you got the drill out and my whole face is numb anyway? Fuck it. Let's just let's just kind of take care of all this here. And then if you got another crown later, it's a good opportunity to be like, well, let's check in on this. Are we good? I mean, again, maybe not scheduling an appointment specifically to do that, but if I'm already there, I mean, and I don't know, look, I'm almost 50. I don't know anybody who's not at the dentist for something at least once a year these days. You know what I mean? I got a crown, I got a filling, I got a whatever,
Well, dentistry being installed often is adjusted very poorly by the paper mark method, even though the patient may feel it seems okay. And that's just because, again, there's a lot of subjectivity and what forces are there.
Yeah, you were telling that today. I'm like, oh, shit. Every time I had somebody tap me now, I'm like, what were they looking at? I mean, were they the good-looking people or the bad-looking people? I don't know,
No one is actually the good-looking people. No one really, despite dentistry's resistance to facing this truth, no one can look at the marks and know what they mean. I used the T-scan for 40 years. I can't look at the marks and tell you which one means what. Just because I use the computer, I recognize there is no way to know. The first time I ever saw a really eye-opening experience with that issue alone, the paper mark issue alone, T-scan 1 in 1984, a patient was complaining about a tooth, upper right molar, And I recorded them with my cryptic knowledge of the T-scan at the time, and came up a very high force on T-scan 1 on this same tooth. And I went to mark the area that the T-scan isolated, and it was a pinpoint paper mark. It was really small, just like that woman from Brazil who had these 2 really small paper marks. And at that time, being 1984, I was taught that the big marks were the forceful ones and the little marks were light force. And none of that is actually true. Any mark size can be any force, but which is also something we've proven and dentistry doesn't also want to face. And so I went in and I said, okay, I'm using this computer for the first time. Let me adjust that one spot. And I took a little bit away, again, computer guided micro adjusting. And the patient goes, wow, that is so much better. And then I knew, this was 1984, I knew the paper mark method didn't work. I said, that's crazy, because there were dark paper marks in other parts of the tooth that were registering low force on the T-scan data. And so it became very apparent that the ink doesn't predict what dentistry was telling us it predicts. And now 42 years later, they're still teaching the same outdated concepts and unwilling to measure at the real compromise for the patient's well-being. And your crowns, for example, you could have those crowns, Matt, and they could feel fine to you, but have, let's say, excess force in some aspect of 1 or 2 of them. And then over the next few years, your dentist says, your gum is receding from that crown, Matt. When I put it in, the gum line was right up next to that crown. I didn't have any gum recession. I made it to the gum line. I don't know, you must not be brushing or flossing correctly because your gum line is receding there. And what's actually happening is the forces are driving the gum south. And this is a very common thing in dentistry, that a crown edge gets exposed from bite pressure that takes years to show up. But the dentistry sees it as like, it must be because the area is not being kept clean, when it's actually the forces driving the gum down away from the edge. So,
is there a way of finding out who has this tool? Is there like a listing or something?
Yeah, is there a network?
It seems like 5% means I'm calling 100.
I've had some massive periodontal surgery, and I was told that it was a bacteria that my body just couldn't fight. Right? He said, I know you're flossing, I know you're, but now I'm going, oh shit, I know my jaw feels pretty tight. Yeah. Is how much of it was the bacteria versus I'm sure he wasn't quote unquote lying to me, but how much of it would have been prevented had all of this structure been a little bit more aligned?
Well, I wouldn't want to misinform the listeners and yourselves that periodontal disease is a bacterial infection. Bite problems can worsen an existing gum condition, and most of what the gum causes as far as periodontal disease is recession and abfraction. Abfraction is cracking at the roots. It doesn't cause tissue loss and gum pocketing. It can't cause it. But it can crack the root of a tooth. So you get these dents, and when you get these dents along the gum line, the gum has to move away because it can't attach there. So it goes down. And so you might have had inflammatory periodontal disease and needed surgery for that. If you were getting gum grafting for recession, that's a different story. That's coming from the bite, and no amount of grafting the gum will stop the gum from receding. It's not possible because the root will keep cracking as long as the bite is not addressed. So to answer your other question, TechScan, the company, certainly can provide you with people who have the technology. I would say it's more important to see someone who's a known trained expert, and to find.
That was going to be the next question. Is just because it's one of the 5% doesn't mean they actually know what the hell they're doing.
Yes, I'm contacted all the time by dentists. I bought the T-scan, it doesn't really work, I'm not sure what to do with it. I'm like, yeah, you need to be trained chairside by an expert. Myself and one other doctor train the dentist one by one in their office with patients, because that's the only way to really learn these skills. It's not a skill set that you just have because you're a dentist. You have to learn how to record extremely high quality data with it. You have to learn how to read that data and understand what it means, and how to translate that data into micro computer guided bite adjusting, which is the process that you have to learn with patients. So, people who come to a lecture and see it, they don't go home and become good at using it, right? So to find those trained dentists, there's a website, www.digitalocclusionseminars.com. And those are all the trained chairside experts from different countries around the world. And we continue to train dentists who are interested. The difficulty is not the training, it's that the political environment still is not telling dentists you really should be using this. The experts in the implant world, they haven't come to it. The experts in the gum world haven't come to it. The experts in the TMJ world continue to say the bite the bite is not an issue, it's a psychosocial problem. And it's not true at all. The TMJ is caused by hyperfunction of the swallow mechanism backfiring on the patient, tightening up their muscles, coming from their teeth, and the friction on their teeth. And this is something we've proved over and over and over again. There are over 100 treatment studies on TMJ alone in the literature involving the T-scan and EMG. And the newest one is this cortisol paper.
Mm.
So I'm like wondering, people with TMJ, my wife's got really bad teeth. You're talking about these pinpoint, problems on the paper. I'm wonder if that, could be that easy, I don't want to overly reduce everything, I should say, but it feels like, listen, I've gone back to dentists and be like, something ain't right here. And they show me one time they showed me with a mirror, and it was like just a little tiny piece that they were like, yeah, this is it. It's just this little tiny thing. They took it out and it was like, I was brand new. And I'm like, Jesus Christ, this little tiny, I feel like the Princess and the Pea or whatever. Yeah. You know what I mean? You're like 1,000 mattresses. I feel this one little tiny thing. So.
Well, it can certainly be like that, but TMJ patients really often don't complain about their bite. They use their bite, they clench and grind their teeth. They're not aware of their bite being
I see.
unpleasant. And those that have an unpleasant bite also may develop TMJ from crowns being put in that the bite is thrown off, and things like that after finishing Invisalign or braces, developing TMJ from the bite mechanics that have been set. Wow. So, but the interesting thing about your point is that the paper can't measure any of these things that matter to the central nervous system and the neurophysiology of swallowing in a way that's predictable. And so patients struggle. And because of that, the struggling, dentistry has said, well, it can't be the bite. We've adjusted the bite and we think, and the people didn't get better. So the bite isn't causing TMJ, when it's actually the quality of the bite adjusting has been totally ineffective and inaccurate, highly subjective. And so your wife's TMJ, for example, unless her teeth were treated in this specific way that deals with the friction, the duration of the friction, she'd continue to have her bite keep tightening up her muscles. It's an ongoing, every time she swallows. We swallow 2,500 to 4,000 times a day. So every time, yes, that's to
that's a fact I was unaware of.
That's crazy.
That's to lubricate your throat and to lubricate your mouth and to help bacteria not attach to your teeth. There are all kinds of reasons we salivate, but the process involves putting your teeth together and swallowing. And every time you put your teeth together, if there's exaggerated friction in your bite, it magnifies the amount of electrical activity that leaves. And over time, this is what tires out the muscles. And this is why a person who might have TMJ and get treatment that doesn't involve their bite in these specific ways, their symptoms just keep getting worse. They don't get better. No matter, they can control them somewhat with a mouth guard. They can control them with some medication or by trying not to eat chewy foods that might tire them out or hurt them. But they can't stop the neural side. The neural side is the causative side. So as long as her bite keeps doing what it's doing, she's going to have TMJ.
That's crazy.
Yes.
I feel like, is your current mission basically just training up docs on how to do this better? Is this kind of like what you're doing now? Or do you just sort of spread the word when somebody asks and just use it in your practice?
Well, my mission has been twofold since the 1980s. I've been trying to change dentistry to adopt a very important technology that it keeps dismissing for a method that's terrible for the public. I mean, guessing at ink and paper that doesn't measure anything about the bite is a heinous choice the profession is making, no matter what anybody wants to say about what they think they know about the bite paper and the way the bite marks look. We've clearly proved is not a good method for patient well-being and safety. And dentists are struggling with it every day in their office. And that's why they can't get predictable bite outcomes, despite whatever education they take that's not involving the T-scan technology. So my first mission is to change dentistry. My second mission is to educate dentists who want to learn about the T-scan. So yes, I travel and teach in seminar format and one-on-one in dental offices as often as there's interest, and that's how someone can learn. You can't learn the T-scan by sitting in a lecture. You can't learn it by reading a book I wrote or by reading a study I wrote. You can understand what was done, but that doesn't make you a clinician. It's like I could read how to do a filling in a book by a famous filling guy, right? And then I still have to go back to my bench and try to drill out teeth and figure out how am I going to cut that tooth that way to do that kind of filling. And those are skills you don't have until you practice them. The T-scan is a learned skill set. So my second mission is to train dentists who want to learn so that they can help more people. And I've been doing that also for 42 years. And the third mission is the newest mission, which is involving your podcast, is to reach the public that there is a much better way for them to be treated. You know, an example would be, you know, if you're a woman who wants to have all her teeth capped like that lady in Brazil, that lady didn't know that after she got her teeth capped that her bite was going to be thrown off. She never considered that as even a possible complication. And that's a routine complication because of the paper mark method. So my third mission is to educate the public that there is a much better, safer, well-being method available to them that dentistry is not allowing them to know about. And so podcasts like yours, journalists looking into the T-scan, people beginning to talk about it on social media is very important because the public deserves to be treated correctly. And this paper mark method is a dangerous method, no matter what any dentist wants to say about what they think they know about it. And that, you know, the fact that it's being taught, continues being taught in every dental school around the world, it doesn't work at all. And no one wants to face that. The public needs to know they're at risk if they go and have the paper mark method used on them. And this is why you went back, Matt, to have you went back and said, my crown isn't right?
Yeah.
Yeah. I can't tell you how many people came to see me with that story where it didn't get resolved, where it didn't, because the dentists are looking at the ink and choosing instead of measuring real bite function. The T-scan measures real bite function, and that matters, to the public in a way they're completely unaware of. And, last thing I'll say about a similar example, let's say I want to be an implant patient. They tell me, oh, my teeth are bad. I have to take out all my teeth, and we're going to make you upper and lower implants like you see on TV with the ads. You see the ads of the people saying how wonderful their new teeth are. The people don't know that their implants that they spent $50,000 on are going to break or crack or come loose in the bone because the bite mechanics were put in with paper and ink. Imagine if you knew, God, I spend $50,000 on my teeth, and then someone's going to guess at the end. I'm going to go find a doctor who has this technology, right? But no one is coming forward with that information. So my third role is to educate the patients that there is a much better, safer, well-being way. It's not a panacea. A dentist has to be good at it. They have to learn how to use it well. It doesn't just work because you use a teeth scan. And having said that, if you're trained in it, you can help many, many people and solve many, many problems that traditional occlusion is unable to address, and much safer for the patients.
Wow.
It's funny. That's just one of the things I love about our show is that I get to talk to people about stuff that I never would have asked even questions on. You know what I mean? Like it never would have occurred to me to pry this deeply into my dentist. Now I'm like, I guess he's the one doctor I haven't annoyed with a million questions. So I guess now I could add him to the list next time I'm there.
Well, he might not know much about the T-scan because it usually gets minimized in public forums. And I don't mean on the internet. I mean, I can't tell you how many lectures I've been in where someone raises their hand and says, "Oh, Dr. Expert, what about the T-scan? I heard it's a great thing." And then the guy on the stage in a room of 1,000 people says, "No, it doesn't work. The sensor is too thick and you shouldn't use it. Just keep using the paper and ink method." And the truth is the reverse. The paper and ink method doesn't work and they shouldn't keep using it. And they should be using the sensor. It's not too thick and it's used all over the world in many industries that this same patient or doctor depends on. When he gets in his car to drive home, when he does telecommunications, every keyboard, when you push on your keyboard, you're pushing on a TechScan sensor. That's the TechScan sensor under there, right? And so these are, incredibly useful things that impact our daily life. But no, the dental patient doesn't need it. It isn't good for them. We don't want them to have it, right? What is the reason? There's no valid reason to take the well-being of the patient and put it at risk by dentists guessing at ink and paper.
Yeah, I'm a big tech guy, and so like I'm like the exact opposite. If somebody tells me, I mean, you just telling me that this tool exists makes me want to play with it.
I already searched the entire website. The closest one is in Wilmington, Delaware, Matt.
Okay.
Yeah.
Which is like an hour from us, which isn't like awful, but it's also like kind of a pain in the ass to drive an hour to go have some dude with a scanner. And then again, it's like, then you got to press somebody, be like, well, how well do you know how to use this thing? You know what I mean? Like, just because you have it, like, doesn't mean you actually can. This isn't important information, but it's half the problem at best.
Well, yeah, but I also feel like if that's the thing, like, let's say your wife drives up to Wilmington and 10 minutes after she gets this procedure done, it's all gone. Like, well, what the fuck is that worth? I mean, that's
anybody
insanely,
who has a problem, for sure.
Yeah,
Yes. Well, people used to come from all over the world to see me because through the years of pushing this onto dentistry against the resistance, I became known as the person to go see to at least have a intelligent T-scan evaluation. I didn't always treat the person. They may not have elected to be treated, but the common thread was they weren't getting rid of their bite problem, their TMJ, their crown discomfort after having their teeth made, and years had gone by, and this was their last ditch effort to get a solution. So driving an hour is not a big deal relative to someone flying from Saudi Arabia or
you're right.
Definitely not.
From the Netherlands. I had people come from all over the world. So however, it would be much better, obviously, if dentistry made an attempt to adopt this and face the truth about the paper and ink guessing method. It's a terrible standard and it puts people at risk. And the dentists don't realize it also puts their own dentistry at risk. If your gum recedes off your crown, Matt, in 3 years, it's because the bite mechanics were poor. If you crack a piece of porcelain off one of those crowns, it's because the bite mechanics were poor. And, unless you were chewing ice or, trying to break off a big wooden stick.
Opening my beer with my teeth. Yeah.
Right, opening your beer bottle.
Yeah.
But, so a lot of times the bite mechanics don't really come into thinking like, you show up at your dental office in 5 years with a piece of your crown in your hand, and the dentist would say, oh, the porcelain chip that happens to the crowns. He wouldn't think that he should have used a T-scan to put it in 5 years ago and it would still be there, right?
Yeah.
The dentists aren't getting the positive, you should buy this, you should have this, like they get about all kinds of technologies, like scanning technology and milling technology and impression technology. Dentistry has adopted those, but this one has been fought back. So that's why it takes an hour to find someone in Wilmington. If they're on that digital occlusion seminars list, they're a person to see. If they're not on that list, they're probably not well trained. And that's a problem for the patients as well. That the well-being outcomes, the high-quality outcomes, come from knowing how to use it, and that's an important thing for people to understand. Having a T-scan doesn't make someone a known user. It makes them an owner. An owner is not. It would be like, Tom, you gave me a set of acupuncture needles and said, "Yeah, go ahead,
go ahead, have at it."
Head, right?
Yeah.
Right. And I have no training, right? Or maybe I'd read a little, and maybe the company would send me a few pamphlets, and you might give me a few words of
I
encouragement.
mean, there's a YouTube video on it. I'm sure.
There's a YouTube for it. Yeah.
Right, I could watch a YouTube video. And again, this is important, that people who do these kinds of medical procedures, whether it's my type of thing or your type of thing, that they be trained and experts, and the public can depend on that. So the T-Scan owner is not necessarily a highly refined T-Scan user, and I hope that comes across in the podcast. That's an important thing to
Yeah, no, for sure.
People should definitely seek out trained users.
So, Robert, this has been great, man. I actually learned a lot today. This is very very informative. Let's get to the commercial for you. How do we get people to you? Like, I'd love to kind of help you spread the word on this thing. I mean,
recap websites, tell us what you're up to, that kind of stuff.
Well, I have a website. It's mostly for dentists about learning the T-Scan, www.drrobertkerstein.com.
And we'll link to that in the show notes.
And we give courses at the Digital Occlusion Seminars website. There's also course information that dentists can go and learn didactically and observe treating patients with the T-Scan. And I also go to dentists one-on-one. As I said, my email is a little complicated. TMJdoc, which doesn't sound complicated. TMJdoc, just the way it sounds, at ix.netcom.com.
Wow. Yeah, we'll definitely link to that. Like,
we'll have that in the show notes.
Yeah,
and that's where dentists can contact me, and patients can contact me as well if they have questions. But certainly, just having your podcast talk about it is very important. This is the public awareness side of it is really what has to drive change, because dentistry is not wanting to face the truth about the paper mark method. And so thank you for having me. And, any help you need from me afterwards about, contact information or stuff, I can certainly give you.
Oh, awesome. Man, it was great. Definitely my pleasure to have this conversation. Like you said, I love these little things because, when people think of like health optimization, they usually think in broad strokes, like, oh, let me do some, like, I'll go to the gym or I'll do, sauna or something. It's like usually these big sort of things. And like dental in general is like one of those things that always kind of falls under the radar. No one's like sitting there talking about, I mean, we didn't get into it today, but I mean, we've talked before about the link between periodontal disease and cardiovascular health, right? Like, and all this other stuff. Yeah. So it's like, you got all these sort of like downstream consequences in your body. You're like, all right, well, you could go to the gym all you want, but if your gums are a wreck, your heart might not be in the best. So it seems like one of those things that we just all overlook. I'm guilty of it just as much as the next guy, so.
I don't think it's been brought to your attention in the way that, specifically the bite is this core problem for all kinds of strange things that go on in the head. Not just headaches and TMJ, but twitches, tics, trigeminal neuralgia, sparking pain in your face. That's a bite problem. We've also treated and studied with research that goes away. So there's a lot of things that happen to people that no one finds any organic disease from, because there's no tumor, there's no cyst, there's nothing you can pick up on an MRI or a CT scan. And yet the person's complaining of some kind of chronic malady. Right. And it's the electrical output coming from the teeth many times is causative. And it can't be seen unless you use these specific technologies and understand the neuro-occlusal physiology.
Wow.
And that's something that's been lost on the profession. As I said, that's why they don't think periodontal disease has a bite problem as a component. Or TMJ is a stress disorder. It's not a bite problem. TMJ is absolutely a bite problem. 100% it's a bite problem.
Well, Robert, thank you so much again. I really appreciate your time, and this was great.
It's my pleasure.
All right, guys. Well, that's another one. And
another one in the books.
Have a great weekend, everyone, and we'll talk to you next time.
Thank you for having me.
Take care.
Be subversive, irreverent.
Health is wealth, but you knew that.
Everybody knows that.
But so is following us on social media at Irreverent Health. And check out our website for more exclusive content at irreverenthealth.com.
Oh, I like this.
Thanks for tuning into this episode of Irreverent Health.